facial skeletal surgery, diseases, and cancers of the thyroid, and conducting laryngology and surgery in head and neck malignancies.
Buonasera, good afternoon. I'd like to first of all thank you, Dr. Higgins, for your gentle presentation. And it's an honor to be here trying to discuss with you about laryngeal and hypopharyngeal T4D if we are truly unresectable disease. I think that we will discuss a little about screening, the quality and the capacity to select patients, respect patients' desires and hope. According to AJCC, T4D laryngeal and pharyngeal tumors are those that or infiltrates the prevertebral cervical fascia, or in cases the carotid, or infiltrates the mediastinal structures. Since the 6th edition, the AJCC divided T4 in resectable tumors, the T4A, and unresectable tumors, the T4D. Some years later, on the 7th edition, they removed and changed this concept. They changed resectable for moderated advanced for T4A, and removed unresectable, denominating T4B very unresectable tumors. Why did it happen? Maybe the AJCC opened a window for our surgeons to do bigger surgeries. Part of this answer, I think, it's because of a huge development surgery technology, more multidisciplinary approach, especially the great development of plastic reconstruction, especially the vascular-free flap transplantation, offering great reconstructions, allowing us surgeons, head and neck surgeons, to do bigger surgeries with negative margins and functional reconstructions. A very important aspect of our discussion is how to classify a patient as unresectable. If we read the papers, we may see that some groups will emphasize a multidisciplinary discussion. Others will give importance of surgeons' opinions, low curability, clinical impossibility of surgery. And others will valorize clinical evaluation and imaging examinations. The T4D patients are really tumor-board patients. We have to be connected, discuss together, putting patient at the center of the discussion, patient expectations, patient's desires, clinical status. And I'd like to highlight the importance of the radiological team with the precise images and staging of these patients. The oncological group with all these new medical possibilities, medical treatments as immunotherapy and others. And what's the importance of us head and neck surgeons? We have to embrace our mission. All the professionals count, and all of our colleagues are waiting for us to say if the patient in front of us is really operable or not. And the most important guidelines, what may they suggest? They really do not suggest surgery for T4D laryngeal and hypopharyngeal tumors. It's interesting because in a less volume tumor as T4A, especially the ones that infiltrate laryngeal cartilage since the beginning of the diagnosis, or even has laryngeal dysfunction, the same guidelines will recognize that the non-surgical treatment has not worked well with these kind of patients, and will suggest surgery as the upfront treatment. So how we may deal with more bigger tumor with the same treatment? That's a question that we have to discuss. We have to offer more It could be amazing if you have something that decrease the tumor volume of the T4D, and probably the way is the biological selection. Neoadjuvant therapy with induction chemo or combine induction chemo plus immuno and restaging this patient with observation of diminish of the tumor and offering at that moment surgery probably is a good way that we could see very frequently. In a more traditional way, chemoradiation, concomitant chemoradiation, and then salvage surgery, that for some situations as not only the guidelines but patients' desires to preserve their voice, we may have to be prepared to continue doing much more salvage surgery than we could like. And if the patient doesn't respond to these clinical treatments, so we have to offer the best palliation that we may offer and discuss a very controversial situation that's heroic surgery. We have some aspects, technical aspects that we may be at our disposal to discuss, and that's the end, and I'd like to thank you for the opportunity.
Thank you very much for that wonderful presentation. Any comments, questions from the panel members? No? Okay. So thank you. We're going to move on to the next